Well, my name's Dr. Gregory Barnes. I'm from the University of Kentucky, and I have a special kinship to you because not only am I a child neurologist who works with patients who have transverse myelitis, but more importantly, I'm a parent of a special needs child, just like you all. And many of the emotions and all the different things that you all have gone through, I've experienced in my own life too. So I have a real heart for you guys, and I know how difficult it's really has been, and will continue to be. And so what I want to do in my first part of the presentation is just to tell you guys that if you all have questions, don't be afraid to stop and to ask, even they're just general questions just related to being a parent of a special needs child. I'll be glad to share with you my experiences. So Sandy gave me the daunting task today of talking about pediatric pain and TM. And the first thing I do want to say is, of course, I'm not a tremendous expert in pediatric pain and TM because it's a relatively rare disease. And indeed, as we saw in some of Doug's original data, only about 1/3 of the patients overall end up having something like neuropathic pain. And Doug, I'm assuming the numbers are so small in pediatrics that we don't have that data for the pediatric populations whatsoever. So this is what I would like to do in the talk today. What is pain at different ages? Can the pain experiences early in life, can those have sort of permanent effects? What are the chronic pain syndromes that could occur in children with TM? And also, what are the treatments available for my child's pain? And then finally, what can I do as a parent to help my child with his or her pain? So pain is really defined by this sort of clinical definition from the International Association for Pain Research as an unpleasant sensory or emotional experience associated with potential or actual tissue damage. What that means in common sense terms is, of course, your body is trying to tell you that something is damaging you, and it tells you to try to get away from it in some shape or form. While I was putting up this slide, my little daughter Amy gave me a quote that I thought was very appropriate. It would very plainly put, "Everybody knows what pain is, Daddy. It's an owie, silly Daddy." So one of the things that's been truly kind of tragic about pediatric pain is that over the years it's really has been undertreated, and we as professionals, and of course everyone as parents, recognizes that has been the case. There have been many reasons why it's thought that children's pain has been undertreated. One of the common myths was that we thought that children's nervous systems were too immature to experience pain. Well, that we actually know is probably wrong. Children, by the time they're born, fully have all of their pain receptors and all of their pathways, their neural pathways, that they can actually experience pain. So that's not true. Children have no memory of pain. Well, we'll talk about that. They do have memory of pain. Children can become easily addicted to narcotics and other drugs. Well, that's not true either. And there were a myriad of other reasons why. The bottom line is that we as medical professionals, we know some about pediatric pain syndromes, but not a tremendous amount. And we know even less about how to really adequately treat it. Chronic pain actually is thought to be prevalent in the pediatric populations. In one survey in the Netherlands, it's a self-reported survey by either parents or children 0 to 18 years of age, they thought that about 25% of the kids had some sort of chronic pain. What was a real tragedy was that there was a major study in children with terminal cancer. And those suffering with chronic pain, the parents thought that the children were successfully treated with medications and other therapies only about 27% of the time. So it's a huge problem, and our success rate as health professionals really is not that great in the pediatric population, but we're working to try to improve that. So our best clinical predictor of pediatric pain, our detector, It's mom. And that's what we need. That's what we as professionals try to do. We try to listen to mom knows what's wrong, you know? And if you don't listen to mom or the caregiver, you're going to miss a pediatric pain syndrome. So how do term babies, neonates, how do they experience pain? How do we recognize it? Well, certainly there are changes in facial expression. A mother recognizes when a child has a different type of expression on their face that really indicates some sort of pain. A big alert to the pain, of course, is the pitch, the frequency, and the duration of the cry. The mother will tell you it's a painful cry of some sort. And of course, those of us who watch babies a lot will see changes in body movements, and of course the moms oftentimes will note changes in the color. A child will typically turn red or pale or some other color. Now, pain in childhood in a child 1 to 5 years of age is a little different in terms of what they actually do. There can be a change in the activity, in addition to all the other symptoms that we talked about in babies. Be a change in activity. A lot of times they'll be quiet and sort of not playing. They'll verbalize pain sort of non-specifically. At about 18 months of age, a child can usually say something like hurt or something like that. By about 3 to 4 years of age, that can really kind of at least sort of semi-quantitate for you exactly how much it hurts. Is it severe or is it just a little pain? They're really more emotional than usual. A child who's in pain has emotions that go up and go down, and they give off these nonverbal cues, such as holding their head, holding a limb, something like that, that really gives a clue as to sort of the location of the pain. Childhood and adolescence, they react to pain a little bit differently. What happens in this age is that it's really the child's temperament that sort of starts taking over, as well as some of the family experiences about pain that sort of modulate how the child actually expresses pain. They may verbalize specifics about the pain, or such as in teenagers, they may actually refuse to talk about it and just be so-called stoic. Older children and teenagers also need the same sorts of observations that you do for the other age groups, because they could also have those types of symptoms as well. They also have the similar nonverbal signs at time. Most of the pain responses at this age are thought to be mediated by both temperament as well as prior experiences of pain at earlier ages. Children who have actually had chronic pain at earlier ages, when they get older, they can have, depends upon their temperament, but they can have actually a greater reaction to pain, saying pain is more severe than you would expect for a given painful stimuli. So the good news about pediatric pain is that we have one study in which we looked at chronic pain diaries from ages 6 to 12, and really the maximal pain ratings really fade with time. And in the memory, it's really only associated with the most severest injuries, so lots of procedures and things like that really sort of fade from memory. So when you talk about trying to successfully treat pediatric pain, there's really a number of different factors that really need to go into truly treating the child as a whole. There certainly is an assessment of both the physical, psychological, and the environmental parameters that are around the child. We need to develop pain management strategies, both medications, which is something I'll talk a little bit about, and non-medication approaches. Later on this afternoon, we'll talk a little bit about behavioral sorts of approaches to pain. And then individual and family therapy as required. There's been a couple of different studies about chronic pediatric pain, and this really takes into account all sorts of different causes of chronic pain. What I've done with these particular diseases is I've sort of highlighted those that might have some relevance to TM, including those with cerebral palsy and especially spasticity, those with malignant tumors, those with scoliosis, benign tumors, cystic fibrosis, intellectual delay, and particularly those with vertebral or spinal cord anomalies. In this particular population, actually, there were only 4 patients who had spinal cord disease. Does that speak to the prevalence or non-prevalence of pain syndromes and spinal cord disease chronically? I don't know. The good news in all of that was that only about 19% of all of those patients had so-called neuropathic pain. Now, let me just define neuropathic pain for you. It's pain due to nerve injury, nerve entrapment, or a benign nerve tumor that's called a neuroma. Oops. Sorry. How do you get back on this one? I think just click off of it. All right. So what is the catch here in this study? And one of the things that was a little disturbing, but is that only an organic cause could only be really identified in about 35% of the kids. Those sorts of causes that were identified in addition to neuropathic pain were things like soft tissue injury, bone and joint related injury, and kidney stones, which are all issues that are sort of germane and relevant to transverse myelitis. What were the interventions that they actually used? Well, they used a number of medications, including non-aspirin-like medications, morphine-like drugs, anticonvulsants, which are medications that are used to treat seizures, antihypertension medications, Valium-like drugs, and there were some use of antipsychotic drugs as well as gastrointestinal drugs. A variety of non-medical treatments were also used, including a big one being physical therapy, which is one of the things we'll talk about today. Another big sort of technique that's used is relaxation techniques and techniques from both psychology and psychiatry. And then there were a minority that actually had to have sort of interventions that were really more invasive, including epidural catheters, nerve block injections, then injections of tendons and neuromas, things like that. There's real good news in terms of this study, in terms of the success. In terms of good outcome, which was defined as a marked reduction in the amount of pain and a marked functional improvement, 65% of the patients actually experienced that. The moderate was 15%, and only about 20% either had an unknown outcome or a poor outcome. So with a proper pediatric pain management, you can actually treat and have a good outcome with the majority of patients. So what possible pain syndromes could you have in pediatric TM? Well, certainly the fear of neuropathic causes neuropathic pain is real. It's 1/3 in the whole population that's in the Johns Hopkins database, which includes these syndromes such as nerve root entrapment, some sort of injury to the nerve caused by the TM itself, or some sort of benign nerve tumor. Spasticity, of course, is a big issue, which is something that Dr. Morrison will talk about a little later today. Soft tissue injury, of course, you all know that skin care is tremendously important in these children with TM. Bone and joint causes, things like scoliosis can be a big issue. Osteoporosis, arthritis can all be big issues. So that's the reason why that attention to good care, such as orthopedic care, is certainly very important. GI problems, yet another cause of discomfort, including things like acid reflux, a stoppage of the bowel, which the medical term for that's called ileus, bowel obstructions, and then urologic problems, kidney and bladder infections, which some people have mentioned already, tremendously painful, stones and bladder spasms, all tremendously painful. And a lot of these different things that we'll certainly talk about in lurid detail in the coming presentations. But certainly attention to these sorts of things is certainly will help prevent pain. So, what would you do if this was your kid, doctor? Which is a question I always try to ask myself. So, sort of a step by step. Between you and the pediatrician, the first thing I would do is I would make sure that I would try to identify the doc that's actually going to be most helpful to you if you and the pediatrician haven't worked things out. Ask whether you need to see a neurologist, urologist, etc. Second thing is that after you go to that doctor and undergo treatment, make sure that you ask around other parents, which I know you guys all do. But other parents are a tremendous source of information, and that's part of the reason why this symposium certainly is very, very good for all of us. Thirdly, I'd ask myself, how am I holding up with all this? How's my kid holding up all of this? Do you need to talk about this, okay? And don't be afraid to admit to yourself that, I need to talk about this with somebody, be it another parent, be it a clergy, be it a professional. Don't be afraid to admit that. Your happiness really has a tremendous effect upon your child's neurologic symptoms. I'm giving an example from my own child. My child's autism is much worse when my wife is sad. When my wife is happy, when she's not depressed anymore, his autism is much better. And I've seen this cycle time after time after time again. Has that been studied in any sort of systematic way? No, but I can tell you that's certainly true in my family. If all else fails, think about trying to find a multidisciplinary pediatric pain clinic. Ask for the number of the parents who actually go to that clinic. Ask if they did their child any good. And ask specifically how frequently do they actually treat kids. So since I'm a neurologist, I'm going to briefly talk about neuropathic pain in children. Neuropathic pain is usually pain in the distribution of a nerve or a set of nerves that your child may experience as either a burning or a searing sensation or an electric type of sensation. Oftentimes there's no other obvious GI/stomach or intestinal, urologic, skin, or any bone or joint causes. Can chronic neuropathic pain be present in TM? Well, I think we've already answered that question. Doug's answered it for us. Yes. There's actually very little in the literature actually talking about that. What was interesting about these two particular cases, which were in adults, is that none of the usual sorts of therapies actually work for these two particular adults, including this TENS, which is transcutaneous electrical nerve stimulation, which is something you'll hear about, selective nerve blocks, different medications. And they finally treated this with actual spinal cord stimulation, which is sort of the treatment for last resort of people with chronic pain. But pretty effective, and certainly very effective for these two particular patients. It actually ended up decreasing their pain greatly and increasing their mobility quite a bit. So in children with neuropathic pain, what are our options? Is the pain due to organs outside of the central nervous system? Then we evaluate the location and what the neuropathic pain is. One of the questions I ask myself when I'm seeing a child with neuropathic pain is, what's the quality of sleep? Sleep's a tremendously important part of trying to have effective coping strategies to cope with pain. We know that our bodies, when we have much less sleep, we certainly experience pain a lot more severely than we would if we'd had more sleep, as well as the ability to use positive coping mechanisms is compromised if you have less sleep. You certainly want to evaluate the current coping capabilities of the child that you have. Is there any depression? Is there any anxiety? That certainly can make pain worse, and you certainly would want to treat that. One of the things that I found in my practice is we have sometimes had infrequently had family histories of sort of regional pain syndromes that run in families, and those patients tend to be more difficult to actually treat. The treatment for neuropathic pain is a multifaceted approach. There are lots of medications that can be tried, anticonvulsants, anti-seizure medications, treating depression or anxiety using things like tricyclic antidepressants. If anxiety is a component of it, you got to think about trying something like a serotonin reuptake inhibitor, i.e. medications that are typically used as antidepressants that elevate the neurotransmitter serotonin in the blood. If the child's having trouble sleeping, you've got to consider adding a medication that has sort of a sedative effect, either an anti-hypertension medication such as clonidine, which also seems to help with pain, as well as an anticholinergic, which is called Benadryl, over-the-counter Benadryl. It can actually help you both sleep, as well as it can actually help spare exposure to morphine-like drugs. If a child needs morphine-like drugs, certainly you should give it to the child, but it's relatively rare that you actually do need to do that. If the pain certainly is intractable and your certain medications are not working, you should probably think about adding behavioral techniques. And certainly, if I had more pediatric biofeedback and relaxation techniques actually available to me, I would use them more. But I have used them in other institutions, and they work very, very effectively. So, in conclusion, certainly children with transverse myelitis are at risk for pediatric pain syndromes. Those syndromes are pretty highly treatable, and it's really hard seeing your child in pain. But the way I cope with that is that knowledge is power. You use it to help your child, and just remember that sort of chronic pain really is not likely to continue. Not likely to last, and it is treatable. And always remember what I always tell my wife, and that is we need to find a good set of doctors, the doctors that are sympathetic to your child, sympathetic to you, at least have some sense of what you as a parent are going through. And you need to work with them through time to help you and your child through this. And I'd just like to thank all the members of the audience for listening to me. Especially I'd like to thank Sandy and Doug Kerr and the members of the association for inviting me. I take lots of questions. I'm deluged at home with all sorts of questions at my own house. So feel free to contact me this weekend, and I'll be glad to spend some time with you. Thank you.
All right, we have time for some questions or comments. If people have experiences that have worked for their children, whether it's with spasticity or pain or anything in general, or questions. Sir?
You had maxilla changes used for pain. I had heard that. What is the mechanism of it?
Well, yeah. The question was myxillatine. What is that drug, and what is the mechanism of action? I'm not sure that anybody really knows what the mechanism of action is in pain. It's typically an antipsychotic drug, and that's the way it's used. But I'm not sure that anybody really understands how is the mechanism of action. Most antipsychotic drugs, of course, work on dopaminergic systems, the neurotransmitter dopamine in the brain, and these particular drugs block that effective dopamine. But I'm not sure that anybody really understands the mechanism of action in pain syndromes. Yeah.
But since then, I would say she does not have pain. And so I'm just curious if that's something that is a potential to still be there. If she doesn't have pain now, I mean, I know she's at risk for later on having increased spasticity and things, which could result in more pain. But I mean, she doesn't have it now, and she got it as a very small child. Is there less of a chance that she will have pain later?
I think that certainly is a good question, and a large number of questions on a lot of parents, especially young parents, who of children who had TM. I think.
Is everybody hearing us okay?
It could be a little bit louder.
Could be a little louder. That microphone isn't really doing anything except getting it to the camera.
Okay.
I guess so. I think so.
Okay, so I'm going to try to speak a little louder if people are having trouble hearing me. Anyways, I would certainly say that there's probably, if your child, if she's a couple of years out now, that that I'd say that there's less of a chance of likely of her developing neuropathic pain.
How long did it last, do you think?
How long did the pain last?
Yeah, when she was kind of scratching her legs like you were
For like
saying.
the whole
The
summer.
whole summer.
3 or 4 months.
So like 3 or 4 months.
She scratched her legs with blood. It was really bad.
Did anybody else have that experience?
Every kid went through about 9 months. It would seem like a summer or a period of time where she was constantly scratching her legs and felt, she'd scratch it, bleeding. But then now it's gone. And that was several, because she's 7 now, and that was probably when she break.
Yeah, she was 5.
Yeah.
I
I tend to think that I have not seen it come back. I've seen what happens is sometimes it will stay. And there's this transient event where it goes from numbness, feeling nothing, to a period where it is kind of uncomfortable or just downright painful. And infants especially will do that, this scratching. And I actually see that as a positive sign when it occurs. I know it's hard to tell parents that at the time, but I see it as a positive sign
Yeah.
that there's some sensation returning. And I see it as usually a transient event. There are some who have persistent pain. However, once it goes away, and you can start to see it usually by 6 months, I don't think it really comes back. And I think if it does, you've got to think about something else. Is there now some joint abnormalities? Or
something
is there
else.
a urinary tract infection? It can be the first call for a urinary tract infection, something like
Yeah.
that. So if it comes back, I would be actually very aggressive to look at what might be causing that.
Yeah. Go ahead.
I was curious, having gone to meetings where there were both adult and pediatric patients and being a pediatric neurologist, it doesn't seem like after that initial period of neuropathic pain, most kids have pain. So I was curious to ask you, parents, how many of your children have persistent pain? Because I think it may be a significant difference between pediatric and adult
Yeah.
forms
Yeah.
of TM.
My daughter was 2 when she developed arthritis, and she's 24 now. And when it first hits, there's a horrible pain. It goes away, but there's always pain from the other orthopedic and other issues that develop. But I think that's like separate from pain. She's had like 3 super bad episodes of transverse myelitis. And with those individual episodes, the pain is horrific, but then it's gone. But, now she has all the other orthopedic issues and things like that, So I think it does resolve.
So it seems like based upon the experiences that after a year or two, if the child really hasn't had developed ongoing active pain, that is probably at least the experience here that it's probably much less likely.
So at least out of the acute phase, it does point to the other things which can cause pain syndrome.
Right.
Speaking of the secondary side effects, the orthopedic issues, how would you treat the pain of Osgood-Schlatter? That seems to be what's putting you back in the picture. The average
Well-
walk is causing unhealthy Osgood-Schlatters.
Well, oftentimes in
Did everybody get the question?
yeah. Well, the question was, how would you treat the pain of Osgood-Schlatter's disease? And basically, what that is that's deposition of bone at the end in the knee joint, and as a result of that, you can get very a lot of pain with that. And typically especially you see it in just even normal kids, and use ibuprofen and things like that, which really treats the pain very, very well. Now, it could be that with your child that there's other issues going on. There actually might be arthritis that's actually in the joint that might be aggravating that. So, and treatment of that might involve a surgical excision or something like that might be more curative of something like that. You'd have to rely on your orthopedic doctor to actually evaluate that to see if in fact that there is some sort of arthritis going on in there, and is it some sort of use issue that needs to be addressed in the joint itself. Okay.
Do you ever find in the acute phase of the ATM,
Mhm.
the lower back pain, and then now when she tries to, we try to have her walk around her braces every day for at least an hour or so, and she will still complain in the same area of pain. I mean, she doesn't have chronic pain just being in a wheelchair, but when she gets up and ambulates around, she'll kind of say in that same area.
Yeah, that was certainly.
Can you just repeat the?
Yeah, sure. The question was her particular child had lower back pain in her initial presentation of ATM, and now remind me how many.
17. It happened a year and a half ago.
Yeah, so she's now a year and a half out, and then sometimes she still has some backache in that area. Well,
She's in her braces walking around.
in her braces walking around. And certainly, pain that happens in ATM has a presentation, certainly commonly in the back. Okay, it can be anywhere in the back. Sometimes sometimes lower back, and sometimes it's in the limbs. Sometimes it's in the abdomen. She has involvement of that same region sometimes is probably indicative of the fact that although the area of the nerves that innervate that area, they've healed somewhat. It doesn't necessarily mean that they're completely healed. So with some usage, it could be that you're irritating those nerves once again. But again, to point out what Doug said, that actually might be good, and that she's actually having some recovery in that area. So you might want to view
Now
that
also make
more
sure
as a
that the
positive
brace
sign.
isn't causing it.
Yeah,
Because
I mean
brace
that's the other
is-
thing is to evaluate the
I see, okay.
yeah is to evaluate that area actually from an orthopedic standpoint to make sure that there's nothing orthopedic-wise
Now,
causing
the other
that
thing that
pain.
can be helpful is a set of stretching exercises before she gets up. So in some cases, it's kind of a focal spasticity in the back, and that can be painful when you then activate the erector spinae muscles back here. So if you stretch them out, just do 5 minutes of stretching before getting up and walking, see if that helps. But it may be helpful. Sir.
One of the implications from your slides was that in families with autoimmune diseases, there can be recurrence. I'm just wondering if you have been able to work out some algorithm in terms of the laboratory testing that give you reason to believe that a particular child of a particular family with autoimmune disease would be more likely to have a recurrence versus another child.
Okay, good question. Can we predict a recurrence, and is there kind of an association with other autoimmune diseases? Because I mentioned thyroid disease and multiple sclerosis. There is a link probably between thyroid disease and transverse myelitis. We think that that's the truth. We have not been able to detect anything so far with, say, diabetes or even multiple sclerosis. I mean, those two probably are distinct entities. Now, when somebody presents with a first attack of transverse myelitis, there are things that we can identify which make us very suspicious that a recurrence will occur. And those are humoral derangements such as autoantibodies that we can detect in the serum. Don't even need to detect them in the spinal fluid. So we run tests regularly now, specifically one, SSA and SSB, are two studies which are commercially available, but we run them as well. And we think it actually predicts quite well somebody who will go on to develop multiphasic transverse myelitis. And in fact, several groups independently have come up with this. There's a group at Mayo who has done this, and they've come up with it, and we've kind of just shared data with each other. even though we had no idea that the other was doing it. They've come up with the same thing. So there are these autoantibodies which, if present, predict a recurrence. They also predict a response to plasma exchange. So that if somebody has a recurrence and has these kind of autoantibodies in their blood, they're much more likely to be responsive to plasma exchange. And we would tend to go to that as an earlier therapeutic option. But if somebody has had one episode and has some of these autoantibodies, we also look for other diseases that come with that. Lupus, Sjogren's syndrome, sarcoidosis, those types of things. And that would actually shift us more towards immunomodulatory treatment on an ongoing basis for a period of time, rather than maybe even waiting for the third or fourth attack. So that's how we think about that.
And is there any data in the does that data distinguish between pediatric versus adult populations?
Our data included pediatrics. The Mayo data was just adults.
Okay.
And so the numbers are pretty small so far for pediatrics.
Yeah.
There's a question in the back? Yeah.
My daughter is very spastic. Now, should I stretch her
Her daughter is very spastic in the morning. Should she stretch? Yeah, definitely stretch. But we'll talk a lot about spasticity management. But yeah, that's going to be very important. How old is your daughter? She's 9. Yes. Yeah, stretching. I think we'll all say as we
Yeah.
go through is going to be a very important regimen to get into on a daily basis. Some she would be able to do, perhaps. Some you'll need somebody to do with. For example, when patients come to see me in the clinic, I'll actually kind of do stretching with them, and it's kind of weird to see because the patient will be on a table here, and I'll bend their leg up all the way so that, we're kind of close face to face here with the hip, knee, and ankle flex, which is a nice time to get some more of the history, but it's actually very important.
Go ahead, Frank.
Stretching is something that we talk a lot about in pediatric rehabilitation, and one thing that I tell parents is there's a big problem with stretching is it's very boring. I mean, just to sit there and stretch a child for 1 minute is hard. So what they really should do is go through a nice, easy, prolonged stretch, 5 to 15 minutes, maybe 2 or 3 times a day, just to get those tight muscles out. One thing you could do is warm the child's muscles prior to the stretch. That makes it